Dear audience, I would like to present you the current status of my PhD progress. My name is Anita Gréta Perényi, and the title of my thesis is Assessment of Nutritional Habits of Pregnant Women. As an internal medicine resident, my vision is to normalize gestational diabetes with lifestyle medicine and nutritional counseling. And my mission is identifying the dietary factors modulating the therapeutic response in the population. Dietary supplements became popular, especially among young fertility-age women in the recent years, but we still don't know the clinical significance of them. That's why both of our projects are focusing on this interdisciplinary field. Our first project is investigating the efficacy and safety of polyunsaturated fatty acid and vitamin D supplementation on carbohydrate and lipid metabolism parameters among patients diagnosed with gestational diabetes. Gestational diabetes affects approximately 14% of pregnancies, and it's been associated with a wide range of adverse maternal and fetal outcomes as well. The standard care of it is based on lifestyle modification, but sometimes it's not enough, and insulin administration is needed. Our intention with this study is to find further safe and effective substances in the prevention of adverse events related to the disease. There are suggestions in scientific literature that a low-grade inflammation may play a role in the pathogenesis of the disease, and omega-3 fatty acids and vitamin D seem to be promising with their potential anti-inflammatory properties, and they may improve insulin sensitivity and glucose tolerance. Our clinical question is the following: is higher polyunsaturated fatty acid and vitamin D intake better in gestational diabetes than standard care alone? The population is patients diagnosed with gestational diabetes. The first intervention is vitamin D. The second one is polyunsaturated fatty acid. And third intervention is the combined supplementation of the two compounds. The comparator is standard care alone. Our primary outcomes are maternal glycemic and lipid parameters, and the secondary outcomes are fetal anthropometric parameters, mode of delivery, and maternal inflammatory parameters. We hypothesize that the mentioned interventions has beneficial effects compared to standard care alone in this population. The clinical research implication is improvement in maternal metabolic parameters and decreasing neonatal complications. The first domain of the search key refers to the population, and the second one refers to the intervention. During the selection process, we found 26 eligible full-text files and 2 additional with citation chasing. We are in the figures and tables phase, and I would like to present you one of the most interesting ones. This forest plot shows us the mean differences of the changes of HOMA index with 95% of confidence level. HOMA index does not have a unit. It's a ratio calculated by fasting plasma glucose and fasting insulin levels. This is a marker of insulin resistance. Pregnancy can be a physiologic status of insulin resistance, but it's more pronounced in the presence of gestational diabetes. In a metabolically healthy pregnancy, it's rather around 1.5, but in case of gestational diabetes, it can be around 2.5 or 3 or above. If we can decrease it with 1, counts as a good metabolic response. The data table is composed by 739 patients in the intervention group and 732 patients in the control group. All of these included studies are randomized controlled trials. We made 3 different subgroups based on the types of the interventions. In the vitamin D group, the result is minus 1.01. In the fatty acid group, the result is minus 0.61. As I have mentioned, these are mean differences, which refers to that when the value is minus, the intervention is more beneficial compared to standard care. But in these groups, there were high heterogeneity, and these are not mathematically significant effects. But if you take a look at the combined supplementation group, the result is minus 1.13, with low heterogeneity, and this is a mathematically significant effect. Why is this interesting for us? Because with insulin treatment, we can prevent adverse events related to hyperglycemia, but we cannot cure insulin resistance. I would like to talk a bit about our second project, which is an observational study. The title of it is Investigating the Effects of Diet Composition and Micronutrient Intake on Carbohydrate Metabolism Parameters and the Development of Gestational Diabetes. Macronutrients like carbohydrates, proteins, and lipids provide us energy, while micronutrients like vitamins, minerals, or trace elements are involved in biochemical processes and metabolic pathways. The exact recommended diet composition, even in guidelines for managing gestational diabetes, remain uncertain. And our intention with this study is to find more modifiable risk factors regarding to the micronutrient intakes of the individuals. For performing this, we are planning to use the following methods. A food frequency questionnaire for identifying the most common dietary patterns among healthy pregnant individuals with those, to compare it with those patients who are developing gestational diabetes. A 3-day food record, or we can call it food diary as well, performed in each trimester of pregnancy, which is a common use tool for the estimation of energy and nutrient intakes of the participants. We aim to use calibrated and validated measurement tools in the evaluation of anthropometric parameters of the participants. And because physical activity can have a huge impact on metabolic health and weight gain as well, we are planning to incorporate a standardized physical activity questionnaire for our measurements. For verifying our data, we are planning to use serum and urine biomarkers as well. The inclusion will be in the first trimester of pregnancy, and we are planning to follow the participants 6 weeks after the delivery. The inclusion criteria is adult pregnant individuals with singleton pregnancies, and the exclusion criteria is pediatric population, multiple pregnancies, and patients diagnosed with eating disorders or poorly controlled internal medicine disease. Our clinical questions are the following. What are the most beneficial dietary patterns for metabolic balance? What proportion of nutrient intake is provided by dietary intake compared to dietary supplements? And can higher micronutrient intake have a preventive effect on gestational diabetes? The population is pregnant individuals. The exposure will be various diet with multiple micronutrient supplementation. And the comparator is no micronutrient supplementation. And our primary clinical endpoint is the development of gestational diabetes based on the oral glucose tolerance test in the second trimester of pregnancy. We hypothesize that higher doses of micronutrient intake has preventive effect on gestational diabetes. The clinical research implication is positive effect on maternal metabolism. As a summary, you can see the 2 ongoing projects of us with the planned dates of submissions. And thank you so much for your kind attention. With a quote from an unknown person, healthy eating during pregnancy can be the first gift you can give to your child.
Thank you very much for your nice presentation. So this combination is very important, and if it's about supplements, it's very critical. Is there any guideline we can read or we can check for our patients or for relatives if something like this happens?
Thank you for the question. In the guideline of World Health Organization, the standard approach is to supplement iron and folate during pregnancy. And there's a limited role of the multiple micronutrient supplementation or supplementing any combined micronutrients. And in this guideline, there is not enough data regarding to establish any causative relationship between the micronutrient supply and gestational diabetes. Anyway, there are other guidelines like the ASPEN guidelines, but in this guideline, there is still not enough data regarding on this clinical endpoint.
Okay, thank you.
Hi, congrats on your nice work. My question is regarding the first project. It is possible that I just missed it, but how much vitamin D was prescribed to the patients? And was it a daily administration or weekly?
Thank you so much for your question. This is a really important detail. There were high heterogeneity between the studies, and we tried to count or sometimes estimate a daily dose because the administration was different as well. For example, in some studies they supplemented twice a day. In some studies, higher doses, but weekly administration. And the average intake was around 3,000 international units daily.
Per day, yes.
Yes.
Okay, thank you very much.